Okay, our next speaker will be Ryan Kong, who will be speaking on outcomes of open, robotic, and minimally invasive approaches for thyroidectomy. Ryan.
All right, hi, my name is Ryan. I'm one of the current PGY2s at Downstate. The title of my talk is Outcomes of Open versus Robotic and Minimally Invasive Approaches for Thyroidectomy. And thank you, Dr. Sundaram, for mentoring me on this project. So I have no disclosures to report. Just an introduction, the open approach to thyroidectomy it's known to be safe and the gold standard for the surgical approach for generations. And in the recent years, especially in the Asian countries, there's been a desire for improving the cosmesis of the scar, which led to the development of robotic and endoscopic approaches. Recently in the Americas, it's also starting to pick up a little bit slower than the Asian countries. And in several published studies at the institutional level are suggesting that, robotic and the minimally invasive techniques are, when employed in the appropriately selected patients, can have comparable outcomes to the open approach. And so my project is utilizing the American College of Surgeons National Surgical Quality Improvement Program database to compare the outcomes between the open versus robotic versus minimally invasive approaches. So we specifically used the thyroidectomy targeted procedure database between 2016 to 2020, and then we included all adult patients 18 plus that underwent a thyroidectomy and then separated them into the three groups listed below. We collected the patient demographics, which is listed on the right, and then the outcome measurements we looked at were 30-day postoperative complications for post-op hypocalcemia, recurrent laryngeal nerve injury, hematoma, and then readmission for specifically hypocalcemia. And then, I guess just to note for the patient demographics, this database doesn't include like the usual stuff like age and BMI and comorbidities like diabetes, so that's certainly a limitation here. It'll be with chi-squared, to do univariate analysis between the listed demographic variables and then a multivariate logistic regression model, including all of the demographic variables listed here to determine the odds ratios for the outcomes between the three groups. For our results, so we had a total of 30,000 patients that underwent a thyroidectomy between 2016 to 2020. Majority of them were open approach, 99.6%, and in the robotic and the minimally invasive groups, only 50 patients or 60 patients for the past 4 years in those groups. Just looking at the patient demographics, the only significant thing between the three groups was the tumor classification, in which the robotic group had the most T0 patients. 11.1% versus 1% versus none. And then nothing else was significant. Looking at just the univariate rates between the outcomes of the groups, we again see no difference in hypocalcemia, hematoma formation, laryngeal nerve injury, or readmission for hypocalcemia. When we did the multivariate controlling for all the demographic variables that we investigated, because there's not a lot of patients in the robotic and the minimally invasive groups, but we can see that there's an increased odds ratio of developing a postoperative hematoma in the next 30 days after surgery in the robotic group, but a very wide confidence interval. So discussion, robotic and minimally invasive approaches for thyroidectomy, very small percentage in the United States, at least in the NESQIP participating hospitals, and in patients with thyroid cancer were less likely to undergo a robotic approach. As I noted, there is an increased odds ratio in our multivariate analysis for postoperative hematoma formation, but because of how wide the confidence interval is, it could be influenced by a lot of factors, especially since we didn't include age and BMI and other comorbidities. But there's certainly something to look into, into the future. And then so, additional prospective studies with longer follow-up periods are needed to better identify the ideal candidates for these minimally invasive approaches. In terms of future directions, so you know, I said the problem was that we didn't have like all those you know, usual demographic variables. I recently was able to combine, so the general database has all that stuff, but they don't have the thyroidectomy specific stuff. I was able to combine the general and the thyroidectomy specific databases, so hopefully, you know, when I redo the analysis, redo the study, we can add those variables into the multivariate to see, you know, what the truth is. And then, you know, hopefully, if it's possible to add more years beyond 2020, I think it's up to 2024 now. So hopefully we can increase the sample sizes within our minimally invasive groups. These are my references, and thank you.
All right, thanks, Ryan. Any questions for Dr. Kang? Yes, Dr.
Yeah. So the question was, how was it defined, the minimally invasive group? So there's a variable in the thyroidectomy database that actually is like an approach variable, and it would define it as like open or minimally invasive or robotic. And then so I got those variables and combined it, but
Okay, I'm still going to ask,
yeah.
what is minimally invasive and the difference between that and open?
So open involves making you know, usually a cervical incision, usually horizontal. The minimally invasive approaches, I mean, there's from my understanding in the literature, you can make an axilla incision that then travels up into the neck, or I think even to like just like in the clavicle, you can go up. So that would be the definition.
And then this,
Yeah.
The transaxillary approach is robotic.
Oh.
Minimally invasive is when you make a small incision less than 2 centimeters in size, and your volume should be less than 2 centimeters per meter square.
But still in the neck.
Still in the neck.
So what are not included here, if I understand it correctly, are the retroauricular incision, or it is included? It's robotic.
Robotic, but I don't think at the time
Transaxillary and transbreast. So this is a good start, definitely a good start, but when we expand the study of all of these approaches, we have to include also complications that are related only to those quote-unquote minimally invasive procedures. What are the complications related to the retroauricular? What are the complications that related to transoral, mental nerve? What are complications to something was very popular, I don't hear about it much more, which is around the nipple. We're talking about hypoesthesia or anesthesia of the nipple. So this will help us to compare these approaches. What you did, you related only to the complications, which also can happen in routine open thyroidectomy. But that's an excellent start.
and I guess my point about the minimally invasive, if it just means it's a 2 centimeter incision, then that's self-reported, as opposed to, I mean, I would think there should be some overlap, I know. So is there overlap with the open and minimally invasive? I mean, unless someone decides the 2 centimeters is minimally invasive and reports it that way, it may fall under open.
Congrats on the database studies are always great, so congrats on doing that. There are two things you didn't mention. You didn't talk at all about statistical power. You talked about wide confidence intervals, but I think your main problem here is power. If you're talking about, thousands in one group and 50 and 60 in the two others, your power is minuscule to really find a difference. And I think that's a fundamental issue with extending this longer or getting BMI data or other stuff. It's still going to be, if you have 99.6% of people doing one approach, to try and really compare things is truly impossible, especially since we have no understanding of why people picked a particular approach. The allocation bias issue is huge. So, you know, it's laudable, but I'm not sure. I think you're trying to tease things out of this database that just can't be teased out with the nature of the data that's there. But you deserve to be commended for trying.
Thank you, Dr. Roosevelt.
So the other thing is that why people are trying to do the minimally invasive and the robotic is better cosmetic results in principle. So the complications that I would be particularly concerned about, hypertrophic scarring, keloiding, especially if you're making an incision that's 1.5 centimeters to 2 centimeters to do a minimally invasive thyroidectomy, you're going to be stretching that incision a lot intraoperatively. That may not be so good for the skin when you close it. So that's what I would be really interested in seeing when you actually have the numbers of patients, and unfortunately you're limited by what the database provides you.
I just have one kind of question related to both of those comments. Did you look at, are there any databases that exist outside of the US where the minimally invasive approach might be utilized that could give you higher numbers for the robotic and minimally invasive?
I was looking into, I think there's this Japanese like national database that is like for insurance claims that some of the studies are starting to utilize, but you know, certainly an interesting one to look into. I don't know how to get access to that, but you know, for the future, that would be a good approach to go for.
You know, one of the things that was brought up at the AHNS when you presented it, which is a valid point, is how do you control for surgeon experience? So for example, in ECOG 3311, the surgeons were chosen depending upon their experience with the robot and the size of the lesion and so on. Whereas here, this is just a complications analysis. So we're really not controlling for surgeon experience. And one of our surgeons who was a surgical resident at Downstate, who's now a big teacher of robotic thyroidectomies, was the one who raised this complaint. So
I have one more comment. Ryan, thank you for, I think you need to address when you publish it, I don't think it's minimal invasive, because what is more minimal invasive, going over the thyroid with a small incision or coming from the axilla or the mouth? What is more invasive than, you know, I think the motivation is mainly the scar, and that's how you need to define it. It's not a minimal invasive. I think it's more invasive. It's about the scar, avoiding the scar in the neck, which is, you know, in some areas in Asia, this is a very important issue, and that's where it's coming from. In our population, it could be beneficial, as was said, for patients who want to avoid keloid scarring, or patients who are very concerned. But for the vast majority of our population, I don't think it's less invasive.
So I'm told we now have capability for questions from our Zoom audience too. So any Zoom audience questions? And we have Dr. Lucente there as well.
I had several questions, but fortunately Dr. Rosenfeld and Dr. Sundram asked them, so I heard the answers.
All right. Thanks, Ryan. So the first sign of good research is generating a lot of audience input. So thanks, Ryan. All right.